Welcome to the Cognitive Processing Therapy tapes on Psyflix. This first part is a little overview of what cognitive processing therapy, or CPT, is. CPT is a brief treatment, usually not much more than 12 sessions. It's evidence-based. I'll show you the evidence at the end, and it's a specific form of cognitive behavioral therapy. It falls under the umbrella of cognitive behavioral therapy, but the emphasis is on the cognitive part. And it's a treatment that can be done either in groups or individually, and we have it also with or without an account, and I'll talk about that in a second. So you can see the different formats that we have for CPT. CPT plus A means CPT with written accounts, and that is how it was originally conceived. We thought they needed to write a full account of what the trauma, their worst trauma was, and then read it to the therapist, read it themselves every day, and then do it a second time. And then you'll see a study in a minute where we also tried it without doing the written accounts, and we just call CPT. And it can be done in individual, it can be done in group, and in some residential programs, even some outpatient programs, they do combinations of individual and group treatment. So how does CPT work? First thing we have to do is challenge their avoidance. We go through and explain what the symptoms of PTSD are, but we save avoidance for last, because that is what maintains PTSD and is normally what drives it for years on end. So we talk about that. We talk about the symptoms of PTSD. We're looking to help them dissipate natural emotions, which means if they're hardwired and they have emotions that come directly from the event, fear or anger and so forth, we want them to just feel their feelings about that. But the other emotions they have are based on their cognitions, their thoughts about the event, and those may not be accurate. So if we change those thoughts, then the emotion is going to change. So you don't need to do it over and over and over again. We've also found that not only about the event itself or events themselves, clients tend to overgeneralize, and we call that overaccommodation. They're thinking about their everyday life. So they bring the trauma forward and assume that no one can be trusted, that nowhere is safe, that they must be in control all the time, and so forth. So we have modules at the end of the therapy that cover the overgeneralized beliefs that they developed as a result of the trauma. We talk a lot in CPT about stuck points, and a stuck point is a thought. And that's what we are looking for, is the ones that have led to emotions that have kept the PTSD going. In other words, have kept them stuck in their PTSD. So it's a statement that's probably incorrect, but they thought it at the time and they never questioned it again. And so they continue to have their PTSD symptoms as if what they're saying to themselves is true. And those thoughts lead to negative emotions like guilt, rage, fear, etc. So if you change the thought, the emotions are going to change, and the PTSD symptoms. So CPT is going to systematically teach them to look at their thoughts and look at the facts and see how they can change. So the first sessions are the educational sessions. We're teaching them to about PTSD. So we teach them the symptoms of PTSD and why they got stuck. We sort of figure out, what they got stuck on and what their stuck points are. And then the first assignment, after they've learned about PTSD and they hear about what CPT entails, is we have them write an impact statement. And that means they're writing a statement about why they think the event happened. Not what happened, but why they think it happened. And then they bring that back into the next session and they learn, they go through that, and we work up a stuck point log so we can figure out what we're going to be focusing on over the course of therapy. And then before the end of the session, they're going to learn to distinguish events, thoughts, and feelings. And the client is going to, they may or may not write a detailed account. If they're doing CPT plus accounts, then they would be assigned to write an account of the event from the time they knew they were in danger until it ended. and they want to include sensory details, thoughts, emotions, and so forth. And they do that after they've done a week of doing, or a session of doing the ABC sheets at home. Then they do the account, and then we have them do it a second time. But if they're doing CPT, we just do more ABC sheets and focus specifically on the traumatic event, not everyday events. From there, we start actually changing the therapy a little bit. We've already started doing Socratic dialogue, which means asking questions to help the patient figure out how they got stuck or why they think the way they do, and start to sort through why it may be incorrect by the questions that we ask. We don't tell them that it wasn't their fault. We have to help them figure out that it isn't their fault. So they get a challenging, they're going to look at explore a single thought with a series of questions first, and they start learning how to ask themselves questions. So they're starting to take over the therapy fairly early on by session 5. And then they're going to learn about patterns of thinking that have gotten them stuck. And then they have, finally, the final worksheet that they get pulls it all together, and they have an alternative thoughts worksheet. And as an example, when we're usually on around session 4 or so, we help them understand the difference between different kinds of events and the way that we typically look at them in society. That there's a difference between something that's unforeseeable, something that they played a role in, or something that they intended. And if they intended it, then the appropriate response is guilt. But many times our people with PTSD have, instead of having sadness or regret, they blame themselves for the event that happened, even if it was totally unforeseeable. So this is one of the turning points, I think, in the therapy, when they recognize that they didn't intend the harm. They intended something else entirely. Moving into, after they've done those kinds of worksheets and they've really worked through the trauma itself, they start moving forward into the over-accommodated, the over-generalized beliefs that they have. And we have modules or a handout for them and worksheets with the alternative, to help them develop alternative beliefs about really common themes that get disrupted as a result of trauma. And those are self or other referent beliefs about safety, trust, power and control, esteem, and intimacy. And by the time they get to the end, those last 2 sessions, they're going to have some behavioral assignments. They're going to be asked to give and receive compliments and write them down and see if they have any stuck points about doing that. In other words, we're trying to get them to interact with other people. And we ask them to do at least one nice thing for themselves every day that's not earned. They don't have to deserve, they can just have it because they're worth it. So we're trying to work on their both activity level and getting them to do more things, but also on their self-esteem. And then at the last session, when they're working on intimacy issues, they also are asked to write a final impact statement. Now, what does it mean that this trauma happened to you? Not what you wrote the first time, but now that we've done all this work together, now what do you think about all these issues in terms of why did it happen and these themes that we've been working on? CPT is going to use a series of progressive worksheets. So we're building to that alternative thoughts worksheet, and we use a combination of worksheets and handouts that are going to illustrate the tasks we're trying to get them to learn how to do for themselves. So we're going to try to help them change from extreme to more balanced thinking. The therapist is to be Socratic, in other words, not too convincing, but trying to get them to think about, by asking them questions. Where were they? Who else was there? How tall were they? How much time did they have? What was their intent? And those kinds of things. So the therapist is kind and curious and helps the patient really think through their own unique experience. And we don't make assumptions about that, but help them understand what their assumptions at the time were. So originally, CPT was a group therapy when I was first developing, and that was back in 1988. I did an open trial with it. I had, by the time I got a randomized control trial, I had done 84 pilot cases along with my graduate students. And when we do CPT plus A, I think I've mentioned we do the written accounts between 3 and 5, sessions 3 and 5, and we were doing it with group treatment there. Now, I wouldn't advocate for that now. Without the account, the therapist and the patient are going to spend an extra session with the ABC sheets, and they have more time to do Socratic dialogue from the stuck point logs, from the items there. Variable length treatment is going to be the next iteration of CPT. So we did CPT plus A, then we did CPT with 12 sessions, and then variable length CPT was allowing them to stop when they got to a good end state. In other words, not when they just didn't have PTSD anymore, but when they had very low scores. And when one of my colleagues first did that, she found out on average they didn't need 12 sessions, they only needed about 9. And only one person at the 3-month follow-up still had PTSD. I've also done it with military. They don't do quite as well as civilians. Veterans are tougher to treat and active duty are tougher to treat than civilians are because of the training they get that sometimes leave them with stuck points. There have been intensive now outpatient treatments, and that's the latest version of CPT, and we've had only one randomized controlled trial at this point on that, but there have been a lot of studies that have been done, like open trials in programs where they do CPT. First they did it for 3 weeks and had lots of filler programming. Then they moved it to 2 weeks, found out it worked just as well, and that was the part that the patients liked the best. And now they've even done it with the randomized controlled trial with 1 week. And it's been done with group and individual with 1 week, a combination, so they get all 12 sessions in. It's also been done as individual therapy with 1 session in the morning, 1 session in the afternoon with time in between to do worksheets. And so they do, and usually get through 10 sessions. And so they decide which of the modules they're going to focus on. The reason we went from CPT plus accounts to doing it CPT without the accounts for the most part is because I did my second randomized controlled trial. I did a dismantling study, and I compared CPT the way I originally developed it and compared that to CPT without written accounts, doing an extra session of ABC sheets. And then later we divided up, instead of doing safety and the challenging beliefs worksheet, which we're now calling the alternative thoughts worksheet. That used to be in the same session in original CPT plus A, and now we've divided that into 2 separate sessions. But that was the biggest change. And then we had a third condition, which was written accounts only, and that was set up to be very much like prolonged exposure. So they, at least it was the way we were taught to do it at the time. So they had fewer sessions, but they were 2-hour sessions. So there were 2 1-hour sessions, and then they had a meeting with the therapist, then they were put in a room to write for an hour, then they came back, read their account to the therapist. The therapist was not allowed to do cognitive therapy. They could talk about, is there anything you got stuck on? What did you have the most emotion for? Did you leave anything out of the account? So they could ask all sorts of questions, but they could not do the same kind of challenging and Socratic dialogue that we do in CPT. And you can see from the results on this slide, I was quite surprised. I thought that the CPT with accounts would be the best. That's why I developed it that way. And it turned out the CPT without the accounts had a much faster trajectory of change. And the CPT is the blue line, and that is the one with the accounts. And they didn't really improve until after they finished the accounts. And then they had a clinically significant change. They caught up in the end, but they didn't do any better than the people who got CPT without the accounts. And there was a significant overall group effect between CPT and the exposure-only group. By the 6-month follow-up, they were pretty close to the same, but it took that long before they were caught up. So we stopped doing, from most of the studies I did, we stopped doing with the accounts because it had a 15% higher dropout rate. People would drop out when they were assigned to do the account. And so if you have a lower dropout rate and a faster recovery, you can see on that slide, by session 4, which is 2 weeks into the therapy, they had a clinically significant improvement. And that was having done the impact statement and the ABC sheets and some Socratic questioning. This is what some of the worksheets look like. This is an ABC worksheet. Something happens, that's A, the activating event. B is the belief or the stuck point. And C is the consequence. So it's something happens, I tell myself something, and then I feel something. So the example here is I was in a car accident. It was my fault that my friend was badly injured, and I feel guilt. And so this person happened to write some things down below after they did some Socratic questioning about it. Sometimes they write things, sometimes we don't usually assign it to begin with, but we ask them to think about it, and this person decided it really wasn't their fault. This is the same sheet when we get done with all the other worksheets. So the ABC sheet has gotten pushed off to the left where you can see A, B, and C. So there's the event, the thought, and it's the same event, the same thought and feelings, except now later in therapy, we're asking them to rate how much they believe it and how much they are feeling something. By then, we've gone through the challenging questions, which you'll see on the tapes. And you'll see we used to call them problematic thinking patterns. Now we're just calling them the thinking patterns worksheet. We used to call those challenging questions worksheets. I couldn't change that, but I did change the above, where it says alternative beliefs worksheet. We have a new book coming out next spring, and we're trying to get less challenging. But anyway, there's the questions that they answer about whether something, that specific stuff point they answer the questions for, and then they go on and answer questions about, is this one of your typical patterns? Is this one of the things you typically do? And then they come up with an alternative thought, and they rate that. And then they rate their emotion and how much do they believe that old thought. And hopefully you're going to see that change and drop once they've figured out what the facts are. This is a simplified worksheet. And we use that sometimes when people are adolescents, have lower reading level. It doesn't have the problematic thinking patterns in it, but if somebody's really struggling with that large worksheet, we can move back to this one. We don't prefer it, but it works, and there's fewer questions, and basically what can I tell myself, and then how do I feel? No rankings in there, no ratings of how strongly they feel. And this is probably the lowest level one we have, which is with pictures. And this could be the whole challenging beliefs worksheet because there's a series of questions down below that the therapist can ask. But what's the event? What are they thinking? And how do they feel? When my colleagues did cognitive processing therapy in the Democratic Republic of Congo, they didn't even have that much. They had no paper, no pens. Most of the women were illiterate. And so they actually turned the ABC sheet into a dance move. It was jump, tap, tap. So it was event, thought, feeling. And so then they say, okay, what was the event? What was the thought? What was the feeling? And so they could use that and talk about it then and do the Socratic questioning. And they would practice with that on the way home when they were walking with each other, going to and from the sessions. We also do CPT in groups. You won't be seeing that on these tapes, but CPT actually is fun to do in groups. Typically, they're a little bit longer. They would be 90 minutes. Probably better to do it that way than take 2 hours with a break because it's hard to get them back from a break. We like to see about 6 to 8 people at least. If you have too few people, if anybody drops out, it's going to start feeling like individual therapy with multiple therapists, and, so you really want to start with enough people. But if you don't want to have too many, if you have 12 or more people, it's going to be hard to manage all their homework assignments because you have to take them and read them and mark them up and give them back to them at the next session. But what you do is find stuck points that they have in common, and they'll use a whiteboard or a flip chart, and they'll say, it's all my fault that X, and everybody will write on their own worksheet, it's all my fault that it happened because whatever. And so then they'll ask themselves the questions, or they'll discuss it. One person will volunteer to be up on have their stuck point on the whiteboard or the flip chart, and then they'll bring everybody else in. So one of the other things that the group does is bring everybody in so that they're all responsible for the group, and they're going to take over as things happen. So they start by establishing some rules, like turn off your cell phones, don't be late for the session, bring your homework, and they'll come up with some really good homework, some really good rules. They'll decide how many sessions somebody can miss before they're out of the group and have to go to the next group. So they're going to look for similarities across the stuck points that they're working on. So the main role of the group members is going to be to participate in and out of the group. In other words, they're going to do their practice assignments, bring it in, and help each other. And sometimes people are actually quicker to see each other's stuck points and why that doesn't make sense than they are to see their own. So you get some interesting cross plays, like you couldn't have gotten there in time. I mean, that was too far away. And a member will say that, whereas we would ask a question, how far away were you? And have them try to figure that out. But sometimes the members can offer examples, provide support, and so forth. So as the therapy develops, the therapists are going to stand back more, and the patients and the members of the group are going to increase their involvement. And we see a lot of good interaction between them, a lot of good social support. And it's the same phases of treatment. They have pre-treatment, they have the education, pre-treatment to make sure they're appropriate for the group. The processing of the trauma would be the ABC, the impact statement and the ABC sheets, and then they start to learn with the exploring questions and the faulty thinking patterns. And then they move to that big worksheet where they learn to do come up with a good alternative thought that they can believe in, and then they move into the themes. And then facing the future is when they start talking about, in those last sessions, about who do I want to be. That would be in the esteem session, and intimacy and relationships and things like that. So those topics also come up as they start to look to the future, as they don't have PTSD anymore. The advantages of a group is that you can treat more people at the same time. They can, as I said, help each other correct, and keep an eye out. The one thing you do have to, we did do research, and with military, we found out that a fair number of our active duty military had not just brain injuries from being in combat, but they also still had ongoing symptoms from that, dizziness, sometimes problems in concentration and so forth. And we did find they did very, very well with individual therapy, but they did not do as well for groups. So if you're working for military, you want to screen for brain injury. But if you're working with civilians, you want to look for things like car crashes that had head injuries, battered women, because a lot of the head injuries, a lot of the injuries they get are to head, face, and neck. So they're going to do better with individual therapy, and that may be a screening thing. And we do have really encouraging results. They did really well with individual therapy because you could tailor it to them, and you could maybe use one of the other worksheets that you couldn't do with the rest of the group. This is research. There's just a couple slides here. We have done more than 36 randomized controlled trials. That means it's got all the bells and whistles. They did fidelity ratings with the therapist. They did fidelity ratings with the assessors. Everybody was trained. They were all supervised to make sure that it was done correctly and done well. There are also dozens of other studies that have been done in place, in VA hospitals, in community mental health centers, in all sorts of different kinds of hospital locations. So some people have published articles like that, but these are just the list of the randomized control trials. And you can see the different kind of populations that we've had, quite a variety. And different kinds of traumas across a number of different countries. There have been the randomized control trials. The one that was most impressive to me was the one that was actually conducted in the Democratic Republic of Congo. And that one actually had a control condition. They had 100 women in it who were randomized by village. And they did really well. And they've done a 7-year follow-up, and they're still doing well. And the therapists are still using it. There have been a lot of different modalities. Sometimes CPT was being compared to CPT plus A, or individual and group, compared to group, or combined. And so we've studied all these variations on different kinds of CPT, and then with different combinations of control conditions. There's one now that's not on the list that's being conducted right now with EMDR. So we'll see how CPT does compared to EMDR probably in another 2 years. That line that goes across horizontally is where it says 0.8. That is what's called a large effect size, and that's the way you can compare across different kinds of measures, different kind of samples. And so you're looking for something that's bigger. A small effect size would be a 0.2, about a 0.5 would be a medium effect size, and then 0.8 and above is a large effect size. And you can see with the civilians, there's some very large effect size. The study that was done compared with sertraline in Egypt just came out this last year, and they had such a large effect size it wouldn't fit on that graph. It would be like up on the ceiling. And I actually contacted him and said, how did you do so well? And he said, they've never had any therapy before. They've never had the opportunity to have any therapy before. So they were drinking it up. Now this is CPT or CPT plus A with veteran samples. You can see they don't look as good. Let me go back. Do you see how high some of those effect sizes are with civilians? And as I said, with active duty and military, most of the time they get to the point of reaching a good effect size, but they don't have those enormous effects that you see. And there's a couple that are below. The ones that tend to be below are ones that were using CPT as a comparison condition, and I'm not convinced they were actually caring how well CPT did, because they clearly don't do as well as all the other studies. Just in terms of resources, this is my last slide. If you want to get more information about the treatment manual, the self-help manual, training opportunities, finding a provider. We have, I think, 10 different countries now that have providers in CPT. How to become a provider. You can find all of that in CPTforPTSD.com, and that's our CPT website. There's also an online course that goes with the manual. I mean, you need the manual to get the worksheets and so forth, but that has about 36 videos, and it goes right through and gives CE credits and so forth, and goes through all the modules and does troubleshooting and complications that happen, and shows how to manage cases and so forth. The introductory video, if you want to have somebody see an introductory video, they can see that on CPTforPTSD.com, or they can go to the National Center for PTSD website, and they have lots of people talking about receiving CPT. In our CPT for PTSD website, we have a link to a podcast called 10 Sessions, where someone received, across a period of 2 weeks, received 10 sessions of CPT. And she was a journalist, and so she recorded the whole thing and distilled it down to a 1-hour podcast. So if you have somebody who might be interested in receiving CPT, they could listen to that podcast. And as it turned out, the patient you're going to see me treat did listen to that podcast before we met. In fact, he looked up all of my podcasts. We also have an app that is for patients. So if they don't like all the paper and the pencil or using the self-help book, we have an app that has all the materials in it. Now it's set up for the current book, and it will be revised when the new book comes out. So the wording will change, some of the items will change. But basically it has everything you need: the therapist's name, when's the next homework, when's the next session coming. They could put in reminders of when to do their practice assignments, all of the readings, all the practice assignments they can do right in the app. It can be done on either Android or through iTunes with an iPhone, or it can be done with a tablet, which makes it a little easier to look at when you do it on a tablet. But it's a free downloadable app that was developed by the U.S. Department of Veterans Affairs. And that's the end of my talk. Thank you.